Hi, my name is Manali Kamdar. I'm an associate professor at the University of Colorado. My key takeaways or highlights of lymphoma abstracts from ASCO 2021 really was surrounded around a couple of themes of subtypes of lymphoma. For example, in patients with chronic lymphocytic leukemia, there was the ELEVATE-TN study, which established that acalabrutinib was equivalent to ibrutinib in terms of efficacy. However, in terms of toxicity, it was far more manageable with less atrial fibrillation, less hypertension, less bleeding, less diarrhea. So I think that is certainly practice changing for me. In the event I was to choose a BTK inhibitor for a patient in the relapsed refractory setting, I think I would probably lean towards a second generation inhibitor. However, for my patients who are doing well on ibrutinib, I do not intend to switch them to a second generation BTK inhibitor. There was the Captivate fixed duration cohort study that was presented by Dr. Paolo Ghia, exploring the combination strategy of ibrutinib plus venetoclax in a time-limited fashion. And the responses were really promising, stellar. The median follow-up is still about just 2.5 years, so we await longer-term data, but it's a great opportunity for patients to get treated for their disease in a time-limited fashion, not really harness, not really end up with toxicities from long-term therapies, both economic as well as physical toxicities. However, it is not practice changing yet, but it's something that I will certainly be looking forward to. Moving on, I think the clinical trial that was presented by the CalGB group in patients with bulky stage 1-2 Hodgkin lymphoma was practice changing for me. This was a study exploring PET adaptive strategy for patients with bulky tumors, limited stage, bulky being defined as tumors that are more than 10 centimeters. If patients were to respond to 2 cycles of ABVD with the PET2 being Dovil 1, 2, or 3, one could just continue to treat that patient with 4 additional cycles of ABVD without radiotherapy. The PFS at the 3-year follow-up mark was over 92%, which was great. So I think it'll be fantastic for patients to not be exposed to radiotherapy, especially if the PET2 is negative after 2 cycles of ABVD. And then there were some abstracts that were presented exploring CAR T-cell therapy in patients with relapsed refractory follicular lymphoma. As we all know that although patients with follicular lymphoma do enjoy a long survival, there are subsets that frequently experience relapse, and with every relapse, the overall survival goes down, especially in the high-risk cohorts called POD24, wherein the relapse happens within 24 months of receiving immunochemotherapy. And in that cohort, or in these high-risk cohorts, 2 constructs of CAR T-cell therapy were tested. The first one was the Axicell ZUMA-5 study, exploring the efficacy of that agent in patients with POD24. And although the response rate or the duration of response in PFS was slightly lower than patients who did not experience POD24, at the end of the day, it was still fairly promising. It was over 70%. And I think this is a really novel strategy in this otherwise high-risk subset of follicular lymphoma. The LRA study explored tisagenlecleucel in patients with relapsed refractory follicular lymphoma, and although the median follow-up is only 10 months, the promising efficacy cannot go unnoticed. What also cannot go unnoticed is the safety profile. Patients really did not have a higher incidence of grade 3 CRS or even ICANS or neurotoxicity. So we look forward to long-term follow-up data on both of these subsets and trials. And I think the last key takeaway for me was the data that was presented in patients with relapsed refractory B-cell lymphoma exploring bispecific antibodies. I think bispecific antibodies are certainly going to make a big splash, and at some point will hopefully get FDA approval, thus adding to the armamentarium and the toolkit with which we manage relapsed refractory B-cell lymphomas. Specifically, mosunetuzumab plus polatuzumab was explored, and the response rate was very promising. There was follow-up data that was presented looking into step-up dosing with glofitamab, as well as follow-up data on epcoritamab. And although the follow-up remained short, I think the efficacy is very, very good. Toxicity was very manageable. And therefore, I think I cannot wait to see what the next set of clinical trials comes in with new data. I hope it is durable. I hope it continues to be less toxic. But at the end of the day, I think all of these abstracts was certainly a step forward in science, eventually helping all our patients.